Hi, my name's Miranda Marlin, and the topic that I've chosen for my Healthy People 2020 educational objective is access to healthcare in rural hospitals. In order to understand the access to healthcare in rural hospitals, we need to look at the current healthcare crisis in rural hospitals. 83 rural hospitals have closed between January 2010 and January 2018. There are 673 rural hospitals currently at risk for closure. Medical deserts are developing all across rural America. Medical deserts are when there is limited to no healthcare access in rural areas. 77% of rural counties are primary care health professional shortage areas, and 9% have no physicians. So of those 673 hospitals that are currently at risk for closure, that's 1/3 of the rural hospitals that are at risk for closure. 60% of all trauma death occurs in rural communities, but only 20% of the population are rural residents. That's a very staggering statistic. However, it is 2.5% less expensive for providers to provide identical Medicare services in a rural setting versus in an urban setting. However, those identical services aren't reimbursed equally. The rural setting is reimbursed at a lower rate. If all the vulnerable hospitals are closed, there will be 99,000 healthcare jobs lost in rural communities across the nation at an estimated $277 billion loss to the gross domestic product. That is a huge number. So you're still thinking, what does this have to do with access to rural hospitals? Well, why are these rural hospitals closing? We're having decreased patient volumes. Communities need to look at why their specific population is decreasing. Is it because the overall population is decreasing, or is it because of competition from larger facilities? Healthcare facilities in general are having to advertise more because people are willing to travel. Gone is the day of thinking that just because that facility is in your community, that means that patient will come to you. And with technology, you're able to advertise, and with the advances in transportation, driving a couple hours doesn't seem like such a daunting task. Significant capital expenditures. Staying competitive and compliant with federal regulations is burdensome, and sometimes small facilities just don't have the capability of doing that. They don't have the financial means to stay compliant with federal regulations while staying competitive with the neighboring hospitals. If you go in any direction from the critical access hospital that I work at, 45 minutes, north, south, east, west, you're going to run into another critical access hospital just like ours. You need to understand the cost of care. Hospitals really need to look at the cost of each component of patient care to better facilitate insurance negotiations. You need to know how much it costs for a patient to receive an outpatient treatment versus that same kind of treatment as an inpatient versus in the ER versus in the clinic, because you can't negotiate your rates if you don't really understand what those costs are. High levels of bad debt. Due to patients having higher deductibles with their insurance and increased ER visits from non-emergent care. Hospitals are sitting at higher bad debts. There's also been some changes in how bad debt has been reimbursed and the way that you carry it through the federal government. So smaller hospitals can't absorb that bad debt like a larger facility can. So my hospital, Dundee County Hospital, is a county-governed non-profit hospital. It was constructed in 1968 as a 30-bed facility that was inpatient and swing bed. It was designated as a critical access hospital, or a CAH, in 2000, and we decreased to a 14-bed hospital. That's pretty significant. Right now, we're currently in the process of an addition for physical therapy, and we will decrease our patient wing from 14 to an 8-bed hospital. And for some people, that will seem like, how can you manage on a 8-bed facility? But that won't be that unrealistic for us. We employ a total of 80 employees. 4 of them are full-time providers. We have nursing staff, physical therapy, lab, radiology, speech, respiratory therapy. We have a 24-hour emergency room services with basic trauma certification. We have clinical services that also offers a secondary clinic location. We have contracted services with 12 specialty providers. We have MRI, ultrasound, echo, occupational therapy, and nuclear medicine that all come in at various times through the week and the month to provide services to our patient. The mission at Dundee County Hospital is to promote and maintain the health of all of those in our care. The vision is viability through excellence in health services. The guiding principles, the things that really we try to use to guide our patient care, is our patients are our most important resources, and their dignity and worth and culture diversity are invaluable assets. Quality health care must be provided in an atmosphere of service, compassion, professionalism, teamwork, trust, and respect. Our success will be reflected in the number of customers served and judged by our peers and residents of our geographical area. And I think that right there is the reason that I'm doing this presentation. Meeting the unique needs of our rural health constituents is vital to our success. I think when you combine that, those two go hand in hand. Continuous improvements and patient satisfaction must permeate all aspects of our enterprise. Dundee County Hospital must run effectively and responsibly based on sound business practices. Education, communications, and technology are the foundation of Dundee County Hospital's future. So, again, you're probably asking yourself, what does this have to do with my topic? Well, the question that I have is, why is Dundee County Hospital seeing a decrease in the patients in all patient care areas? So how are we going to provide access to our patients? Well, first we have to understand rural healthcare culture. Rural communities tend to be socially and politically conservative. They conform to traditional gender roles, and they're more actively involved in faith-based activities. Rural community members value self-reliance, personal hardiness, and productivity. The meaning of health to someone in a rural healthcare culture means that they have perseverance, functionality, and above all, they have the ability to work. Members of a rural community have a higher health disparity compared to those in an urban setting. So that means that they just have bigger issues with receiving appropriate health care. The disparities increase the more remote the person lives. Patients experience lower access to all aspects of healthcare, and they might actually substitute a primary care visit with a specialty visit or just not see a provider at all. And I didn't really think about that till I was doing some of this research. A lot of our patients don't understand that when you go see a specialist, that specialist focuses on their specialty. Some of them might try and help you with some of your other areas, but they're not a general practice doctor. You can't go to your podiatrist and ask them a question about your heart medicine. That's just not what they're there for. You still need to see your primary care doctor. And if you have an appointment during planting season, that patient is going to skip that appointment altogether because they're just too busy. So what are the barriers to healthcare in rural communities? Why are we not getting access to these patients in these rural settings? Number one, health insurance coverage. Reasons because that they don't have health insurance coverage, the Affordable Health Care Act, even though that was designed to give health insurance to all people, it unfortunately has meant that maybe a few more people don't have insurance, or the people that are able to afford insurance are taking a higher deductible. There's been changes to the Medicaid funding. There's a lot of people that in the past that might have qualified for Medicaid now don't. And people in rural communities have higher poverty levels than those in urban areas. Workforce shortage. Quality healthcare providers and professionals require larger wages, and if you didn't grow up in that community or you don't have a strong desire to be in a rural area, rural healthcare facilities just cannot afford to pay quality healthcare professionals to work there. Distance and transportation. Rural residents have to travel longer distances to see a provider, especially specialists. Social stigma and privacy issues. There's little to no anonymity thought of by a patient, that when they go to the doctor, they think, well, because everyone in the community knows what's happening at the coffee shop, if I go to the doctor for something that's a little bit embarrassing, everyone is going to know about it. So they just think that we cannot give them the privacy that they need. Poor health literacy. People in rural communities tend to be less educated than those in urban communities, and so people lack the ability to understand health information, the instructions, and they're not as confident in their ability to communicate with healthcare professionals. So who does Dundee County Hospital service? Dundee County Hospital is located in a rural community in the southwest corner of Nebraska, and we provide care also to patients in Kansas and Colorado. According to the U.S. Census Bureau in 2016, the estimated total population was 1,831. The age of people living in Dundee County is under the age of 5, 4.2%, under the age of 18, 19.7%, and over the age of 65, 25.8%. So a majority of our population is over the age of 65. The average household size of Dundee County residents is 2.18. The median home value is $70,700, and 69% of the population are homeowners. However, the average annual household income is only $44,583. There's been a negative 7.4% change in total employment from 2012 to 2016. I think that's probably pretty typical of most rural communities. They're struggling to improve employment. Annual statistics for Dundee County Hospital: we have about 9,500 outpatient visits per year. We average about 1,250 inpatient days. This number, I think, was most surprising for me. Our occupancy rate for the last 18 months, so October 2016 to March 2018, was 11.61%. Urban hospital occupancy rate in 2013 was 63%, and the rural hospital occupancy rate was 37%. I'd read an interesting statistic when I was doing some research for this project that the year with the highest hospital admissions was in the 1980s, even though right now we have millions more patients population. Our practices for admitting patients is significantly different. So what are some of the strengths and weaknesses of Dundee County Hospital? How are we going to be able to facilitate giving that access to healthcare in our rural community? Well, our strengths are we have the ideal nurse to patient ratios. We always have 2 nurses and 1 aide on staff, whether or not we have 0 patients or 14 beds. And if we have the 14 beds full, we have at least 1 more nurse on staff and probably 1 more aide. We're a committed staff for making a successful hospital, and we're engaged in providing quality patient care. Our weaknesses, we lack a lack of trained healthcare professionals, nurses and specialty providers. We sit at 30 to 40% nursing shortage at all times on the hospital side. We have a lack of knowledge on how to increase our patient volume. The executive staff doesn't really understand what we need to do in order to bring patients back to our facility. And we have a lack of finances to provide educational opportunities. Right now, we are on a freeze for any educational opportunities for our staff outside of the medical staff. And the medical staff, i.e. the providers, that's built into their contract. Nurses, respiratory, physical therapy, everyone else has to pay for any continuing education, any additional schooling, all of that on their own. So my recommendations for Dundee County Hospital in order to provide access to healthcare in our community, we need to become more involved in the community. And you're thinking, well, what does that really have to do with healthcare? Well, our patients need to know that we are invested in the success of our community as well as our hospital. If they know that we're committed to them, they will be committed to us. We need to find out why the patients' numbers have decreased. Are we just losing that patient population base? I can think in the last 3 months, the death to birth ratio is 10 to 1. We need to have aggressive recruitment of specialty providers. And by aggressive, I mean thinking outside of the box. Who are we sending our patients to when we need to do a referral? What specialties are they? You know, what specialists are the surrounding facilities using? Are they willing to come here on those days? If they're not, go outside of the hospitals that we typically refer to. We need to have a better system in place for follow-up care. The patients that come to the ER and they need to have something taken care of in the clinic the next day, it shouldn't be the oncoming shift in the morning's responsibility to understand what needs to happen. That patient that has sent out labs in the clinic and we say we'll call them with the results, and 2 weeks later we still haven't called them and they're patiently waiting, but they're not going to call because they don't want to bother us. It's our responsibility to follow up on that. We cannot lose any more patients than what we already have. We need to advertise swing bed as an option in our facility. Most patients don't understand if they have surgery outside of our facility, they can come and recover in our facility. The advertisement needs to be on multiple media platforms. We need to teach, reteach, and then teach again to the staff what services our facility offers so that revenue can remain in our facility. My last recommendation, healthcare is mobile and patients are willing to travel. It's our responsibility as a facility to find out what our community needs the most and provide that to them. It may require an adjustment to the way that we deliver healthcare. Maybe the services that we provide are no longer relevant and we need to adjust that. How am I going to know that my recommendations were effective? I'm going to see an increase in patient census in all viable patient areas. And I think the key word is viable. I could say in all patient care areas, but maybe all patient care areas are no longer viable. Thank you for listening.